Let me welcome you all to the webinar. My name is Edward Kataika from ECSA Health Community, and I lead the Tanzi Health Economics program. The webinar series is organized by the Tanzi program, primarily for the ECSA Health Economics Community of Practice, and we focus on topics relating to health systems strengthening. We pay particular attention to issues where health economics approaches and tools might be employed to inform resource allocation and other health policy decisions. So much as this is primarily targeted at the community of practice for the ECSA region, participation is open to everyone interested in the discussion topics. And through these webinars, we aim to strengthen the capability of health planners and economists in ministries of health and research institutions by facilitating their engagement with technical experts from various fields. So technical experts come to present and they learn from them, but they also learn from each other how they use health economics to address the various health policy challenges in their work settings. So there's learning from experts, but also learning from each other as a community of practice. The webinar is also an excellent forum where economists dealing with policy interact with their counterparts from the academic and research institutions. And we believe that such interaction between economists that are working in a policy setting and their counterparts that are research-oriented, that interaction is necessary for evidence-informed policy making. As you will have seen from the announcement, this webinar is organized jointly with the World Health Organization, Regional Office for Africa, and we're addressing the issue of the health workforce. ECSA Health Community and the WHO collaborate in supporting countries in the various technical areas, including issues of human resources for health. In May 2024, the Africa Health Workforce Investment Charter was adopted in Windhoek, and it established a set of principles and commitments to align the health workforce investments through evidence-based inclusive planning developed via national dialogues and formalized in investment compacts. And health workforce modeling is a powerful tool for stimulating policy reforms and investments. The WHO, in the context of the health labor market analysis, is investing in building tools, capacities, and partnerships to advance health workforce modeling and integrating it into broader health system planning. And this is an area where the Tanzi program is collaborating with the WHO, contributing to the strengthening of capacities for health workforce modeling. And I need to mention here that the Tanzi program is also into modeling, as you will hear from two of our presenters from Imperial College. So we'll be further exploring other areas of collaboration with the WHO towards strengthening health economics capacity on the continent. So by way of introduction, I wanted to say that, but at this point, I would want to invite a colleague from WHO, Dr. Juliet Nabyonga, who will be moderating the webinar with me, to take the floor and moderate the next session. Juliet, please.
Thank you. So, I guess, yeah, I'm unmuted. Thank you so much, Edward. And welcome colleagues online. So happy to be moderating this webinar. Juliet Nabyonga, I've had a very long career with WHO at the different levels of the organization, but I'm also faculty, professor of public health in Northwestern University in South Africa. And I've been working with colleagues on these things and many aspects of health economics within the region. So I'll co-moderate this webinar with a colleague, a friend, Edward. So in the next perhaps 1.5 hours, we are going to have presentations. We are going to have discussions. We are going to have interactions to advance this area. I want to start with a few housekeeping issues just to notify everybody that this webinar is being recorded. To again remind time management so we can have an opportunity to listen in, but also an opportunity to participate. I want to encourage a very active participation on the chat, and we'll be raising some of the chat questions on the floor, but also some will be answered directly by the presenters. But we also have a chance for you to raise your hand and ask the question when we get to the Q&A session. I also want to remind our presenters to please keep to time so we can have an interactive session and give our participants a chance to speak to us as well. Now, I'm going to be introducing speakers as they come. Our first speaker this morning is Professor Asamani, who is a health economist and a health systems expert, whose work has been who has informed the transformative policies and health workforce investments across Africa. Professor Samani has been instrumental in building the capacity of ministries of health across Africa to strengthen their health systems. He's a distinguished academic with extensive experience in research and has trained health professionals at doctorate level. He has conducted cutting-edge research and has informed dialogues and decision-making at a continental and a global level. He's published extensively on different aspects of the health systems and service delivery, and currently serves as the World Health Organization Africa Regional Advisor on Health Workforce Development. In the next 20 minutes, Professor Asamani will speak to us about using health workforce modeling to inform policy reforms and investments in Africa, and he will provide insights from health labor market analysis. Professor Samani, over to you. You have 20 minutes.
Thank you very much, Professor Nabyonga, for the kind words and the introduction. Interestingly, Professor Nabyonga is my mentor in my professional life, so it's great to be introduced by you, Prof. Okay, so please confirm if my slides are visible now.
Yes, they are. Please carry on.
Okay, so if they are just a moment, confirm they are in slideshow mode.
No, there are two. You need to give us only one.
Okay. Better now?
Yes, please go on.
Okay. Thank you very much, colleagues, for the opportunity to look at workforce modeling. I will be a bit brief, but show some insights from work that WHO has been doing. To provide the context, in the WHO African region, which covers 47 out of the continent of Africa, our estimations show that more than 400 million people do not have access to health services, and about 2.5 million deaths that occur annually are actually avoidable. 52% of that is due to lack of access, but 48% due to poor quality of services. This means that the workforce has a role to play in expanding the access, but also improving the quality of services. But if you look at that particular global map that you see, the workforce density across the world, Africa has the lowest, and that means that Africa really has some issues. But it doesn't mean that there's not been any progress that has been made. In Africa, progress has been made in terms of being able to count our health workers. Now we can count more than 81% of the workforce compared to previously where we were doing under 30. And more than 24 countries have attempted to use health labor market analysis to understand their workforce, leading to 41 countries now having new workforce strategies. And our evidence showed that more than 4,000 institutions now produce health workers of at least 255,000 per year, culminating in currently about 5.1 million health workers, which means we now have about 27 doctors, nurses, midwives, pharmacists, and dentists for every 10,000 people. But the challenges are also heavy, that our need-based modeling, which I'm going to show in a bit, shows that there's a 6.1 million shortfall of health workers. But also 27% of the workers we have already trained are not having jobs or not having decent jobs. And this is roughly 1.4 million of those. And migration is here with us. 1 in 10 of our trained workers are already abroad, and 42% want to go. We have a 43% shortfall in budget if we want to absorb all health workers. Meanwhile, those who are working at the facilities have challenges with competencies and also absenteeism. So the issues are many. And the question that people usually want to ask is, so what kind of health workers do we actually need, and how many of them should we aim to train? What health workers will be available based on our training pipelines? How much will it cost us? Can we even afford them? And what is the investment case if you want to pitch for policymakers to put more money in health workers? These simple but complex questions actually gives room to look at the workforce from not just a mere accounting exercise, but also looking at modeling into what will happen in the future based on what we know. As a result, in the health labor market analysis context, we usually model at least 3 different things. What we call need for health workers, where we spend time to look at the disease burden of countries, the population structure along the life course, from pregnancy, childbirth, all the way to adulthood and aging. Then the package of services that need to be delivered, as well as the professional standards to deliver same. We use that to quantify how many health workers are required in the country to make people regain their health or maintain their health. But also we model another one called the supply of health workers, where we look at the inflows of workers from education and from immigration together with those already that exist and account for outflows like retirement, death and disability, migration, and career change, and to understand what caliber of workers and how many will remain in the future. But with need and with supply, remember need is based on disease burden, so it's basically more of a normative, is another dimension we model, which is the demand, which reflects how many health workers can the country afford and are willing to pay to have them. So here is basically about financial ability for the jobs of health workers. So these 3 concepts are things that we try to model in when conducting a health labor market analysis. I will pay more attention to the first and touch on the other 2 as I move ahead. So let me now share with you our methodology for modeling the first. So when we're looking at the need for health workers, there are different methods to do so. We summarize them into 5. To my right is the non-workload related, where we just use health facilities norms and standards to model. And also we can use population ratios or benchmarks to model. These are very simple approaches, but they are more, they are not very sensitive to adjustments that are taking place in the population health need. So the second group, which is called the workload approaches to my left, that you can use health service utilization, which is looking at current level of services that are being used in health facilities to quantify the need for health workers. Or you can adjust that with targets that the policymakers have set for service delivery, and that we call it the service targets approach. Or you go for the last one, which we call the health needs or epidemiological approach, where you look at the disease burden to quantify how many health workers are required. And I want to speak more about that last one going forward. So our conceptual model for doing the need-based modeling is like this. So we first of all start by asking ourselves, who are those in need for health services? To do that, we look at the population of the country, the size of the population, the gender distribution, the age cohort from birth to death, and the location where they are residing, whether rural or urban. That allows us to understand the population dynamics. And we now come to the second one, where we look at the prevalence of diseases and risk factors that affect the population along their life course. what makes people sick or die. We pick all the diseases and their risk factors and look for their prevalence rate so that we can quantify the population potentially at risk. Then we add also public health interventions that need to be delivered. Then we go to the third package, which is the package of services. So based on the essential package of service in the country, we identify what intervention is needed to address each and every disease or its risk factor, and the frequency that intervention needs to be delivered to achieve the desired effectiveness. So that together is what we use to quantify a metric we call the need for health services. So when we quantify the need for health services, we now come to the next one. For the interventions, which health professional is best placed based on their training and competence to deliver the intervention? And how much time will it take to do so? We get that also, and we quantify what we call the standard measure of workload, or some call the productivity measure. And with these two, we come up with how many health workers are required to address the disease burden of the country or a segment of the country, as the case might be. Then we come to the side of how many workers will be available. So that first part gives you how many you need. The second part is how many will be available. We trace it from training schools. What is the enrollment capacity of all the schools? And then we account and take out dropouts, those who will drop out. And we look at those who will finally graduate from the schools, and we add on those who will migrate from other countries. And if they are required to sit a license exams, we try to adjust for the pass rate, and we add those who will pass to the current stock of workers. Then we also adjust for those who would leave the workforce through retirement, death, or migration. And we also adjust for labor participation rate or ability to absorb. And that gives us effectively how many workers will remain in the country and willing to work. With this, we can now compare the need with the supply in terms of absolute gaps, what is the gap, or in relative terms, what proportion of your need you already have met. And we can look at the cost implications and look at what is feasible economically for that country to meet the gaps. And then we look at the budget ceilings, what can be done to bring investments. So this is the conceptual framework that governs how we undertake the modeling exercise that I'll be showing you some examples. Just for the sake of completeness, for those who may want to apply the steps to do the need-based modeling, is to first define for the country, what are the diseases, conditions, injuries, and risk factors that account for at least 95% of the reason why people die or fall ill. Then you quantify the population that are in need. You look at the essential service package to identify the interventions to address them. You engage clinicians within the country to define the workload standard, and then you use a tool to quantify. Very rapidly, this is an example of how this can be applied practically for, let's say, an HIV. So let's take a country that has 5 million people with 15% prevalence rate of HIV. And so from the essential package of services, let's say these interventions need to be provided: testing and counseling, ARV, viral load monitoring, outpatient, inpatient care. So we can quantify, look at the treatment guidelines for HIV in that country. What are the targets for these ones? Then we can look at what frequencies should this intervention be delivered. Then that can come from the clinicians and also clinical guidelines. Then we look at which professional is best placed to deliver the intervention. If more than one professional can do it, what ratio should the workload be divided? Then eventually we come to how many of that professional are required to deliver that one intervention. At the end, we would be able to sum up across all the interventions to see in total how many health professionals are required. So basically, this is how the workings of the model is like. Then when it comes to the amount of time health professionals spend on the intervention, we also differentiate it from being a novice all the way to being an expert. And usually we ask the clinician to give us the average time to represent that of the competent, the maximum time to represent that of the novice, with the assumption that novice will spend more time on the intervention than experts, and then the expert spends the minimum amount of time. So with this, we have been doing this modeling using 3 scenarios. A scenario, what we call the base case scenario, where we combine the current prevalence of the disease burden with the assumption that the health workers will all be trained to be competent. Then the minimum scenario, where we assume the disease burden will take the lower confidence levels and that health workers would be at the expert level and spend small time on the interventions. And then also a maximum scenario where we assume the disease burden will take the upper confidence limits, and then the health workers may assume the novice scenario where they spend more time on the intervention. So this gives us the boundaries. So this is the tool that we normally use for the analysis. It's called the Health Labor Market Analysis Support Tool, which has this particular model that I'm describing in it. And the link is there for those who might want to look at it. Okay, so let me now show the next few minutes some examples of the results. We have done the analysis for across the African region for 47 countries, more of a centralized analysis. And then what we have found is that Africa requires, as of 2022, about 9.8 million health workers across 64 cadres, and this number could increase to 11.8 million by 2030. Now, this is how it looks like. This is how the supply of health workers in Africa is expected to move over time in terms of the rate at which we are producing, with 255,000 on average per year. But this is how the base scenario of our modeling shows how many workers are required. That's the one I said, from 9.8 to 11.8 million by 2030. But if we were to assume the best case scenario using the scenario analysis configuration I showed earlier, this is the dotted line is what is the minimum that is required. So you can see it's still above what the supply line would look like. But if we assume the disease burden will take its worst case form, this is the green dotted line is what is required across Africa. From this, we concluded that in 2022, the shortage of health workers in Africa was 5.6 million, but that shortage is increasing because of changing disease burden and increasing population at a faster rate compared to the production of health workers. Therefore, the shortage of health workers would get to 6.1 million by 2030. And this table gives you more details per broader categories of health workers. So just for a few countries, you see that of Kenya, where the production of health workers, that's the blue line, is almost constant and not meeting any of the scenarios of its need. And you look at South Africa to the left, where they have an aging population with lower production of health workers, particularly that of nurses, and so their need for health workers not increasing rapidly, but because the supply is reducing over time, they are likely to drop and then only be meeting the minimum levels if they don't adjust their production. Then you look at Ghana, where their supply, the blue line, is increasing very rapidly and actually most likely could surpass the base level of their needs, but their challenge is how to absorb them. Then you have a similar scenario also for Zambia. So these are just to give key examples of how this can play out for different countries, even with the same type of modeling approach. So across Africa, we then computed to look at the current workforce compared to the need, what proportion are countries already having. So you can see countries that are in more green tend to have more workers, relatively adequate workers compared to those who are red or, those that are colored red. Then we try to test the validity. Then we realize that countries that have more of their need, at least exceeding 70%, tended to score higher on their universal health coverage scores. So therefore, we thought that this was, this modeling, the result was consistent with the tenets of universal health coverage. So to conclude, I would like to show how to translate this evidence into policy and investment actions. As mentioned by Edward earlier, the Workforce Investment Charter puts out certain principles and commitments to be able to improve workforce. To do so, you need to generate the evidence, including modeling, do a workforce investment dialogue, have a joint workforce investment plan, and if possible, sign that plan into a compact to address issues of education, decent jobs, and ensure that resources are used efficiently with accountability. And so to do that, Zimbabwe, now to show you, somebody will ask, is this need estimate affordable and what should countries do if it's not? Zimbabwe's analysis showed, for example, that their public health sector spending some money on health workforce and the private sector is contributing. So the public sector is that purple line and the private sector is that blue line, how much they are contributing for workforce, remuneration and employment. Then the two of them is this red line. But the training of health workers they are having, plus those they already have, is this black line, which is the amount of money required to absorb the health workers. You can see Zimbabwe did not have absorption problem because they actually had more budget space, or if you like, more positions than the workers that they had. But to meet the disease burden of the country, this is the green line, that is what they required. So you ask the question, can they afford it? The question is no. That green line was needed for Zimbabwe to get to 80% of UHC targets. That required that they needed to add more than 64,000 additional health workers. That includes community health workers at a cost of $501 million over a decade. The analysis showed that what was feasible for Zimbabwe was around 62% or somewhere between 50 and 79%. And for that reason, Zimbabwe prioritized 32,000 new jobs, not the 64. So the analysis showed what they require, but it has, for policy reasons, they have scaled it based on affordability to 32,000. And their progress has been that they did the analysis in 2022. And so Director Jane will come back to this, use the analysis to do a workforce strategy, use the strategy to do an investment plan for the areas that they needed more investment to be able to accelerate. And that plan was signed between the government, different ministries and development partners. And the hope is that this will be able to stimulate more than $460 million over 3 years to be able to give it the big boost that it requires to move the workforce agenda. Some of these analyses are done in several countries. Some of them, those that are publicly available, are here. You can look for them, and then if you want to read more about it. And as part of this webinar, this is one of the collaboration WHO and the TANSI program is working together to advance knowledge as part of WHO's commitment over the last few years of building capacity in this type of analysis. So we did training in 2022 in Kigali, 2023 in Abidjan, and then 2024 in Nairobi, Kenya. And we are hoping that with this collaboration with TANSI, we can even expand capacity to do workforce modeling. Thank you very much for listening, and hopefully we can come back to it if there are questions. Thank you, and back to you, Prof. Nabyonga.
Thank you so much, James, for this great presentation. Again, I want to remind participants that we have the chat live, so please raise your questions as we go. In the interest of time, I want to move on to the next presenter, who is Ms. Mudiara Jane. Ms. Mudiara Jane is the Director of Human Resource in the Ministry of Health and Child Care in Zimbabwe. She describes her journey in this role as being incredibly rewarding, particularly as she focuses on the pivotal health workforce issues. She had the unique opportunity to contribute to the development of Zimbabwe's initial human resource policies during a time when health workforce challenges were becoming increasingly significant. Over the years, she's coordinated the development of health workforce strategies and facilitated training in results-based management, which has deepened a passion for this vital field. She describes herself as truly dedicated to her work and strives to deliver the best outcomes possible. She believes in nurturing the next generation of leaders in healthcare, encouraging young professionals to carry the torch and elevate the importance of health workforce as a cornerstone of Zimbabwe's health delivery system. I think she's best suited to come after James, after the reference to very impactful results from the modeling work done earlier. She will share with us her reflections on the use of labor market analysis to inform health workforce compact in Zimbabwe. Ms. Mudiara, over to you.
Thank you very much, Juliet, and the conveners of this webinar. I'm really grateful for the opportunity on behalf of Zimbabwe to share our reflections in this journey of using evidence to inform policy and decision making. As James said, you note that for Zimbabwe, it has been an interesting journey from evidence to getting the highest offices to consider and approve the strategy and the investment compact. Like James said, the HLMA was conducted in 2022, which was then followed by the involvement of key stakeholders. Why so? Because it was noted that in our previous endeavors to come up with policy, it was mostly internal and inward looking. But the government has got a whole of government approach where we're saying all stakeholders on board, both private and public. So the investment conference then gave us the platform and the opportunity to discuss the results from the health labor market analysis. The recommendations that were adopted then informed the development of the health workforce strategy. We were privileged as a country to be part of those who attended the Africa Health Workforce Investment Charter that James referred to. It gave us an opportunity to interact and interface with other countries, learn from them as we developed the Health Workforce Investment Compact, which was then signed in October, as James indicated. From the comprehensive labor market analysis, we say comprehensive because the country had done a partial health labor market analysis to test the water. So the comprehensive then involved a number of all other categories, excluding the support staff. The key findings for us were that 74,298 health workers were registered in the 72 staff categories that were studied in 2022. The aggregate stock, which is availability, translated to about 74,298, including community health workers. What is interesting is that when it comes to training, the country was operating at 75% of its capacity. You then note when government considered and approved our priorities, training had been number 2, but they made it number 1 because of this, because we want to not only go beyond 100, but also up our skills so that we can produce the cadres that we want. The attrition had been averaging 5.2 per annum, with doctors and nurses, especially the specialists, having an attrition rate of 4.7 and nurses 6.6. The other interesting finding of the HLMA had been the retention wage gap, where the minimum was 450. Sorry, the expected comprehensive transfer wage was US 895 for health workers, and it's something that the Health Service Commission is seized with support from government. In 2020, our health workforce stock was expected, was at 47.5 of the need, which James referred to in his presentation. So this really helped us in terms of presenting the priorities to government, which was done in September 2024 when Cabinet considered and approved the priorities, with education, training, and development being number 1 priority, deployment, utilization, and governance is the second one, retention and migration management being the third one, noting that there are still intentions for some of the health workers to migrate. Having said or listed the 3, it was noted that it was important, and it remains so, to monitor, evaluate, the health workforce issues using ICT, research and innovation to inform decision. And we'll continue to plan now more so with stakeholders on deck. And we are doing that in Zimbabwe through a steering committee specifically appointed to monitor the implementation of the Health Workforce Investment Compact. The decision was then to have, out of the 7-year plan, 2023 to 2030, to have targets that we can possibly achieve in the 3 years. And these are focusing on the education, training, and development, where we want to up the production from the current 3,000 to about 7,000 per annum on a progressive basis. Then we look at deployment, utilization, and governance issues, where we would want to create an additional 32,000 posts, which James alluded to in his presentation. We would also want to achieve geographical equity in the distribution of the health workforce by 2030, and then strengthen health workforce governance and leadership at all levels, because we realize that without a capacitated leadership at all the levels, we'll be setting ourselves for failure. But if they're capacitated, everybody is aware of the strategy, is aware of the compact, utilizing the HLMA results, we can have all leaders encouraging their team members to identify, resonate with the priorities that government approved and also contribute. Then under retention and migration management, we are looking at reduction of attrition from the 8% which was recorded in 2022, as well as progressively increase the remuneration bridge, which I referred to earlier on, as well as increase the employee satisfaction index to at least 80%, because as long as the employees are not satisfied, we don't have committed or motivated health workers to be able to deliver what we seek to deliver by the end of 2030. And then we want to establish a managed migration program utilizing the government framework. The Ministry and the Health Service Commission have started engaging with partners in the UK and in other countries who have got an interest in health workforce matters. Then on monitoring, evaluation, and ICT, like I said earlier on, we're looking at strengthening our health workforce management information system, because this is the premise of the decisions that we make. As long as our health information system is robust and accurate, we can then give or make informed policy decisions and strategies. And we'd also want to strengthen our monitoring and evaluation system and research so that we can generate evidence-based decisions by 2030. For planning and financing, we are making inroads in terms of involvement of all partners, whether they're government and development partners, through the steering committee and also the technical working group on the health workforce matters. We'll also seek with the involvement of Ministry of Finance to up our spending from $9 per capita to about 32 by 2030, and make sure that everyone who is coming on board is aligning their investments with the approved priorities by government. So as a country, we are seeking for the compact now. We are seeking to double the health workforce by 2030, and we'll do that through increasing the training, improving leadership and governance, strengthening monitoring and evaluation, and making sure that we increase the investments with regards to the health workforce. So just in summary, and I would want to flag that it might be important for us, and we'll learn from participants and also the other co-presenters, revisit our priorities, because when we signed the compact, the health workforce space with the investments from the USG, but following the USG withdrawal of investment and also donor fatigue, we might need to revisit our priorities or reprioritize. And for us, like I said earlier on, we have got an active steering committee, which is quite active, meets monthly initially, and then we'll decide going forward. So for education, training, and development, we seek to scale up our capacity from 4,702 in 2025 to about 7,984 by the end of 2026, and we would want to sustain this going to 2030. We would also want to make sure that our training institutions are refurbished and repurposed for handling the increased numbers, and also digitizing health workforce training as well as management. On deployment, we would want to boost the stock of village health workers, and we've got interested cadres through the investment compact, which we have shared widely with all interested stakeholders. We would also want to improve their allowances, create new posts, and to generate employment as a country, and then strengthen leadership and governance, like I said earlier on, as well as invest in comprehensive employee wellness programs, because we need to take care of the caregiver. On retention and migration management, like I said, the Health Service Commission is leading the process in terms of developing a sustainable workforce retention and migration management program with interested stakeholders, as well as improving salaries by engaging Treasury and closing the transfer wage gap. For monitoring and evaluation, it is important for us to continue strengthening information gathering and sharing through the National Health Workforce Strategy and our human resource information systems, investing in digitizing health workforce management issues, as well as promoting health workforce research issues. On planning and financing, we seek to hold the first ever policy dialogues and investment conference. So we stand guided by those who have done it before to give us insights in terms of how we can do that. And then we continue to plan and review as a country with regards to health workforce matters. What has enabled this for us is the high level of commitment. As I speak, every time we get an opportunity to interface with cabinet ministers on health workforce matters, they are interested in the two documents, the health workforce strategy and the health workforce investment compact, which they considered and approved. They want us to give them progress updates, and we'll do that through the Honorable Minister on a quarterly basis. And the Health Service Commissioners as well are interested in this. It's interesting and gratifying when you hear your Honorable Minister, the secretaries talking to the priorities in the health workforce investment compact, because everybody is attuned to the document. They resonate with the priorities because they were involved. So we hope we keeping ourselves or monitoring our progress to the health workforce investment compact, as well as the steering compact. So the health workforce technical working group and the steering committee on implementation of the health workforce investment compact. What we have noted in terms of the requirements for successful implementation is making sure that everybody is on board with the priorities that have been approved by cabinet, and then they align with those, and also focusing on the agreed priorities, mobilizing the appropriate resources as we go forward, and then continuously monitoring and evaluating progress and holding each other accountable. In all this, we have learned that a whole of government approach is very important, because without the involvement of the other line ministries who are critical, for example, for us, the universities are under the Ministry of Higher and Tertiary Education, and we need them for the relevant graduates and postgraduates at the various levels. And the use of HLMA has been beneficial in that our colleagues in Treasury, they believe in figures and numbers. So if you give them the HLMA, you're giving them evidence to support or justify whatever it is that we've prioritized as a health sector. And we take note that there's room for improvement as we learn from other countries, our technical advisors, WHO, in this particular journey. The risk now is the withdrawal of expected donor funding, especially from USG, and also donor fatigue. But as we go forward, we're saying as a country, we have got targets that we have set for ourselves, which we hope to achieve with dedicated support and alignment with the respective priorities. So yes, it's important for us as we reflect that HLMA is important, and we are now starting to build evidence for future reviews starting from 2023 going forward, and every level is being encouraged to make sure that they keep their data when it's required. It's available and fed into the National Health Workforce accounts, and we'll be reviewing our policy using the data that we'll have gathered, and we'll continue to engage in high policy dialogues, making sure that the relevant stakeholders are kept informed and they can guide us and support the resource mobilization that is so required. In developing the strategy and the compact, it's important that we are realistic in terms of what is feasible. Yes, we can shoot for the sky, but we need to be realistic in terms of what is the resource envelope that can then inform the priorities that we can make and present for Cabinet's consideration and approval and review, and then having partners signing and aligning to whatever priorities we've agreed on. I thank you for the opportunity to share this reflection on Zimbabwe.
Thank you so much, Ms. Mudiara. I note a few things that are important in the case of Zimbabwe: sustained engagement and dialogue, whole of government approach, parallel policies to look at health workforce development in general, as opposed to just having numbers and gaps and how to fill those, monitoring and accountability. And when we come to the Q&A, James, I'll come back to you because I'd want you to talk about how this approach factors in uncertainties, like the withdrawal of the USG now, but also catastrophes in economic growth, like we saw from COVID. How does it factor that in? And if that happens, how do we move on with the earlier projections? But we'll come back to that. In the Q&A, James, I would request that you answer that on the floor. Now, I want to go on to our next two presenters, and I'm going to introduce both of them together, and they will have a shared slot of 20 minutes. Our first presenter is Dr. Binglingi, who is a PhD holder in operational research and management from Warwick Business School, and she joined the TANSI program modeling team at Imperial College London in 2021. She has research experience in resource allocation, optimization, project scheduling, COVID-19 pandemic disruptions to health service delivery, and health workforce planning. With his research interests in both public health and operational research, she aims to be a public health operational research modeler for health workforce optimization on resource planning, allocation, and informing decision-making and policy development. Globally, but especially in low and middle income countries. And the other presenter in this same slot is Dr. Margarita Molaro, who holds a PhD in computational astrophysics from the Max Planck Institute for Astrophysicists, and joined the TANSI program modeling team at Imperial College London in 2022. Her research focuses on using computational models such as the TANSI model to quantify the impact of resource constraints on health outcomes. This extends to finding ways in which the allocation of available resources can be optimized to maximize the potential benefit to the population. Jointly, they will speak to us about the TANSI model and its application to inform human resource for health analysis and policy. So, Dr. Binglingi, you're going first, I guess, or Dr. Molaro, over to you.
Yeah, I will go first. Thank you very much, Professor Nabyonga, for the introduction, and thank you very much to the organizers for giving us the opportunity to present this work on this webinar. So before getting started, I'd just like to say that although Bingling and I will have the honor of presenting this work to you today, it relies on a very vast team of collaborators based both in Malawi, Tanzania, and across several institutes in the UK, and comprises experts in epidemiology, healthcare financing, software engineering, and many more. So today we'll discuss the TANSI model. whose goal is very much complementary to the earlier model that Professor Azami talked about earlier, which is to link the impact of human resources for health available in a country with its epidemiology and understanding how the two are linked and impact each other. So in this presentation today, we would like, first of all, to go into the detail of how the Tanzila model works in practice, also to understand how complementarity between different models can be explored. And then we will give 2 examples of analysis that's already been completed. One, looking in detail on how human resources for health in Malawi and future investments in human resources for health can impact its epidemiology using the Tanzila model. And second of all, looking at how the epidemiology of the country, specifically long-term trends in the health burden in the country, is expected to impact the requirements of human resources for health in the country. So starting from the model itself, how does it work in practice? So the model simulates a population which currently is tailored specifically to Malawi, which is characterized by a particular age distribution, sex, residence, housing, diet, income, and a variety of other factors that may impact both the risk and the healthcare seeking habits of individuals in that population. And then based on the epidemiology and the health burden in the country, some of these individuals may start to be affected by one of the diseases that are modeled in the Tanzila, which, as you can see, encompass both major infectious diseases, but also non-communicable diseases and all health requirements linked to pregnancy and labor. Now, once an individual has become affected by a disease, depending on their characteristics, such as sex or income, they may decide to seek care for that ailment. And whether they receive care or not very much depends in the model on the resources that are available by the healthcare system to provide that service. So resources include human resources for health, which will be the focus of today's talk, but also consumables and healthcare facilities and equipment required to deliver the specific services requested by the individual. And it also includes the list of services that are available in the healthcare system of the country, so the policy for essential health package provided in the country. And depending on the resources access, this will impact not only the health outcome for the individual themselves, but also in the case of infectious diseases, the health burden, the overall population, therefore affecting future demands on the healthcare system. So given that this is the framework that we can operate with, you can easily see how the epidemiology impacts the requirements on the health services, in particular the healthcare workforce, but also that if healthcare workforce is limited and is unable to provide the care required by the individual, this will impact both the individual outcomes themselves, but also future epidemiological trends. So let me start by first discussing the analysis looking at the impact of healthcare workforce on the epidemiology. So specifically looking at how different scenarios of human resources for health investments could impact future epidemiology. So in this plot, I'm showing how human resources for health, normalized by those available in 2018, will vary with time. And these we can design as we wish. So the ones we decided to consider were one where the human resources will not be expanded at all. And then others that tracked either the GDP growth of the country and also expected changes in the fraction of GDP allocated to healthcare. So for example, we could consider a scenario where this fraction of GDP allocated to healthcare is fixed, or somewhere this fraction will decline over time, as has been already mentioned by one of the previous speakers, also linked to declines in development assistance for health in the country. Or we can look at more optimistic scenarios where this fraction of expenditure on health may be expanded in the future. And we can then make different assumptions about consumable availabilities during this period. And now, just for argument's sake, I will consider one where consumables are always available when requested. And we can see then that for each of these scenarios, we can look at how the health burden in the country will be affected with time due to different investments. So you can see that in general, even with the more optimistic case of expansion of human resources for health, we would still expect an increase of health burden with time, driven partially by population growth, but also by a rising contribution of non-communicable diseases in the population. And we can also look at this from the perspective of life expectancy from the individual, so removing kind of the population growth from the equation, and we can see that under a no growth expansion, life expectancy would indeed stagnate for individuals, whereas it would increase by about 4 to 5 years in the largest expansion case considered. We can then look at how the total health burden would scale with this growth of human resources for health. So basically, each one of these points in this graph corresponds to one of the scenarios that we've considered. And we can see that in the case where the the fraction of GDP invested in healthcare expenditure is declining, we would expect a surplus of DALIs in the country between 7 and 16% over the period considered. Another interesting thing that the model reveals is the fact that even if this expenditure was scaled above the current fraction allocated to health, we would start to obtain a sublinear trend in the return in healthcare. And this is due to other frailties in the system, for example, healthcare seeking in the population, accuracy of referrals, and quality of care provided. And we can then break this down by all of those areas of health that are explicitly accounted for in the model. So for example, we can look at the evolution of acute lower respiratory infections in the population in these different scenarios of investment and compare it to those due to neonatal disorders. And for example, what you can see here is that the impact on the burden of acute lower respiratory infections is much more sensitive to the human resources for health available because treatment is more effective, whereas neonatal disorders would depend more weakly on the availability of human resources for health. So in summary, the model allows us to quantify exactly the expected increase in health burden due to a drop in the fraction of GDP spent on healthcare. It shows specifically how this lack of investment could lead to a reversal of gains in many areas of health, which have seen significant improvements in the past in Malawi. And also highlights how non-communicable diseases are becoming a dominant contribution of poor health in the country, and that this is poorly impacted by human resources for health. And finally, we've highlighted how frailties in the health system beyond the investment in human resources for health can be highlighted by this kind of analysis using this model. And now I will pass on to my colleague who will complete the presentation.
Thank you very much, Margarita. And so on the other way around, what will be the impact of long-term epidemiology trends on human resource for health needs in Malawi? I'd like to show you another case study. So next slide, please, Margarita. And this is an ongoing work mainly led by my colleague, Rachel Murray-Watson. And we have also designed several scenarios to project long-term trends in Malawi because the future is always uncertain. And today I will focus on only one scenario, which is the baseline, in which we have held the healthcare system parameters as have calibrated to the year of 2015 to 2019. And for the time period of the long-term trends, it is from 2020 to 2070s. about 50 years in the length. And please note that within the introduction of the TLO framework, we could know that we are able to design many other scenarios, including the previous human resource for health investment scenarios that has been introduced by Margarita for sensitive analysis. And for this case study, we have already designed some additional scenarios for this. And these are perfect world, where we have assumed perfect healthcare system functioning and the resources. And then the other is the scaling up of vertical programs such as HIV, TB, and malaria. And then two others is to implement the anticipated changes in the risk factors that could lead to disease such as cardiometabolic disease and cancers. Next slide, please. And this is our preliminary results on the health burden in 2070 as compared with the year of 2020. And please focus on the first, let me introduce the y-axis and x-axis in this plot first. And the x-axis is for the 5 scenarios. But for today in the presentation, I will focus on the baseline scenario, which is the first on the left. And then the y-axis is the fold change in DALYs as compared to 2020 for the year of 2070. So from the first baseline scenario, we could see that among the many causes that have been modeled and simulated here, we see that in the future, in the longer future, 50 years, the DALYs will decrease. But on the other side, as also hinted by Margarita's findings, that the health burdens measured here in DALYs on non-communicable disease such as stroke, most cancers, kidney disease, lower back pain, all these non-communicable disease will increase a lot as measured by DALYs. Next slide, please. And so as such, we have estimated the human resource for health needs in the year of 2070 as compared to 2020. So as similar to the previous plot, the x-axis is for the 5 scenarios and the y-axis is the healthcare workforce time needed in the year of 2070 as compared to 2020. And so in the baseline scenario, we could see that the time needed for all cadres will increase, and expect laboratory and radiography cadre. These 2 cadres will be needed in less than 2 in the fold change, but all cadres, including clinical DCSA, the disease control surveillance assistant, the mental cadre, nursing and midwifery cadre, and the pharmacy cadre, all these will be needed significantly. And the time fold change for all these main cadres will be more than 2. And especially among these cadres, the mental cadre will be needed most significantly. The fold change as shown here is more than 8. And so in the 2 plots, we had also shown several other sensitive analysis scenarios. So the overall brief message here is that our findings are quite robust as tested by the 4 existing sensitive analysis scenarios. All these main cadres will be needed significantly in the long future, as driven by the healthcare service needs and the health burden changes. Next slide, please. And so a very brief summary for these preliminary findings are, firstly, in the long term, we have estimated that health burden of non-communicable disease, such as stroke and heart disease, cancers, and depression would increase significantly. The fold change of the total DALYs of this disease will be more than 4. And as consequently, to meet all those needs from the health services that would be driven by the health burden, And we would have at least more than 100 decrease in demand for clinical nurse midwifery and pharmacy cadre. And particularly, we will have 800% increase for mental cadre in need. And as tested by our sensitive analysis scenarios, we could see that resource availability, including the human resource for health, healthcare system functioning, which are measured by referral practice among the different levels of the healthcare system, as well as diagnostic accuracy, and then the surface treatment scope and reach, and also personal behavior and healthcare seeking. The personal behavior here means the habit of the everyday that could lead to different risk of developing different disease. And all this would impact a healthcare burden and then the healthcare workforce needs. Next slide, please. And so for the overall conclusion, I would like to say that as shown by the 2 case study here, and also by more of our work that has been done and then are ongoing, we are bridging the human resource for health planning with epidemiological analysis. And as such, it is a complementary effort to existing widely used tools, including those developed by the WHO AFRO, as the great one introduced by Professor Asmoni. And for our future, we are aiming to, and we'd like to say that, as introduced also by Margarita, that model is currently developed for Malawi, but it can be used and adapted to countries in similar settings. As such, we are aiming to make our model a research and health policy informing instrument that can be broadly and lightly implemented to more African countries. So for this broadly and lightly implementation in more countries, I'd like to show you a preliminary example, which is a user interface website to predict the health consequences of human resource for health expansion under a limited budget in 2025 to 2034. And this tool is developed for analysis on the human resource for health expansion, but a different from Margarita's one, which is overall expansion of all cadres. This is one is to prioritize the cadres in the expansion. For example, in this predictor, if you allocate a specific proportion of the budget to a specific cadre, and we could input here, we have included 5 main cadres in our model. And the example here is to evenly distribute the limited budget to the 5 cadres: clinical, DCSA, nurse, midwifery, pharmacy, and other cadre. And then we can simply press the button to predict, and we could get the estimate of the healthcare outcome. For example, here for this even distribution for Malawi in the future, in the next 10 years, and the percent DALYs averted as compared to no expansion would be 7%, and this equals to 6.6 million DALYs averted. And also we could see that we could estimate that this is a better strategy than the one that mirrors current cost allocation, informing that in the future we should prioritize the cadres that would be most needed, also considering or balanced with the cost. And I think that's all we'd like to present today. And thank you very much again for the host panelists and all of our great team doing this work. Thank you.
Thank you so much to the 2 presenters. I think we note a whole of system approach to improving human resource, but we are going to come back to some of these questions in the discussion. Again, I want to encourage our participants that please keep the questions coming through on the Q&A. We are going to have a time to discuss, but I want to quickly move on to the next brief presentation on this. Some reflections from Malawi. reflections on the use of the TANS model to inform workforce resource allocation in Malawi. It will be a very brief presentation, then we'll move on to Q&A. So Paul, over to you. Or the colleague from Tanzi, over to you, please, for some quick reflections on this.
Hi, Juliet. I think Tim Hallett is going to provide those reflections.
Tim, please, over to you.
Yeah, I'll be very brief because I'm not really qualified to speak on behalf of those in Malawi who are tasked with this important job. But I would just offer a reflection on the presentations we've seen so far, which is that there's something really exciting and complementary between these two different approaches, which come from two different sort of schools of thought, I suppose, really. So the WHO model has lots of really important features for this kind of work. The deep integration of the clinical input, the reflections of real on-the-ground issues like how performance is affected by experience and so on. And it's a tried and trusted model, which does a very important job and can be used in lots of different places. And I think that's something really, really valuable. There are other models as well, I know. Whereas the Tanzi model is doing something different. We're coming as epidemiologists, in particular infectious disease epidemiologists. So we're always obsessing really about the dynamic interplay between epidemiology, demography, risk factors of various things, and how that evolves and how that is changes in response to intervention, and how intervention needs to shape the epidemiology in return. And so that's I think the unique value of the Tanzi model. I think that there's so it's not like these models are going to say are sort of competing. They're sort of addressing the problem from different angles. One is a really good planning tool, and the other is a sort of more longer term tool for exploration of how changes in policy could propagate into other changes. So I think that's really, and I would love to see in the future these two approaches and others sort of come a bit closer together, so that the benefits tend to be shared across the two. And we're absolutely, would love to explore all of that. And I think that's what our colleagues in Malawi would say. They would say that these planning tools are absolutely invaluable for them. The Tanzi model is adding on top of that interesting insights. Let's try and bring those two things closer together. That's what I wanted to say. Thank you very much.
Thank you so much, presenters. Thank you, Tim. I think now we're going to the Q&A. We have some questions I'll be distributing using my prerogative as chair. I encourage participants, please raise your hand. You can still use the chat, but at this point, you can also raise your hand and answer directly. And I'm going to pose 2 questions to Tanzi and 2 questions to James. And maybe one of these, even the colleague from Zimbabwe may have a word to say, and then we'll be taking questions in two batches. Now, I want to start with Tanzi. I will request you take on the question where Margareta is typing, but I believe it's of interest to all our participants. And the question goes on health workforce and population health needs. The current thinking is around integrated service delivery. In this case, we expect to have services of the different time needs. How does workforce modeling work in cases with the different time needs for the interventions? Now, when we talk of integrated service delivery, I would request that you also think that because you had an example of pneumonia, but there's also the issue of comorbidities, how the model works with that. Then it turns your next question is data. There's a problem of data in many of our countries. And just following this discussion around how do you navigate areas of data gaps, outdated data? I think I will put those two for now. Please answer.
Should I take the first one, Bingling? Yeah, so thank you for the question. So that's indeed a very key aspect of the modeling. So the way the constraints on the human resources availables are implementing the model is by associated each type of service being delivered with a particular time requirement, where this time requirement is specific for each cadre being requested. So each type of appointment will have a requirement, for example, of time from the clinical cadre, the nursing cadre, and the pharmaceutical cadre. And the service can only be delivered if enough time is available on the part of healthcare workers. So there's an assumed availability of healthcare workers of each facility. And as services are dispensed by the facility, the resources are used. And once they are finished, patients are no longer able to receive treatment from that facility. So this is how we ensure that the time requirement and the time available from the human resources for health are integrated. In terms of integration of services, this is something that colleagues within the Tanzi Lanza collaboration are looking at right now. We can indeed account for the fact that different services, so screening, for example, for different conditions as patients are coming in for different types of ailments are included, and we can recalibrate the time requirement due to the integration of that service. So this is something that the model can capture and that indeed we're planning to look at in the future.
Thanks, Margarita. If I may, I'd like to answer the second question on the data. Yes, it's quite challenging to get very comprehensive and with enough details on the data for both the health service categories, health service delivery time, and the data of staff returns on the human resource for health for different cadres that are currently in the healthcare system. To tackle these changes, we have tried to seek advice and help from different departments, such as the HIV department and of course the Ministry of Health. And for the human resource for health, we know that as time goes by and also in the future, there are always inflow and outflow of the human resource for health. In the future, we are aiming to develop a digital platform that could incorporate the dynamic change in the human resource for health in the time. And also, I'd like to say that as the flexibility of the model itself, we could design different scenarios that could reflect the uncertainty of the human resource for health availability. So we could estimate the outcome of different scenarios too. And yes, I hope that's helpful, but let me know if you have any question on this. Thank you.
Thank you so much. Now, James, I want to come to you, and again, I will pose two questions. The first one, a colleague mentioned on the chat that how do you factor in absenteeism? I think the model makes an assumption that if you have health workers there, they will be productive and they will do what they are supposed to do. But we have the issue of burnout, the issue of absenteeism, even presenteeism. So are those factored in? Then also your comment on the sensitivity analysis, because Dr. Bingling is mentioned that there's some sensitivity analysis and it can only go to a certain limit to make sure the model is stable. Now, she touches on issues of climate change, epidemic, but they also economic slowdown, change in government priorities. How does the WHO Afro model take this into consideration? So those two to you, please. Over to you, James.
Thank you very much for the very nice discussions and really good for the learning. So regarding absenteeism, yes, at the moment with the analysis that I showed, we had assumed that health workers who are available and are deployed to work will be supported and that they will be accountable for their work, and so absenteeism was not accounted for. Nevertheless, the tool has the ability for you to adjust if you want to factor in absenteeism, because you can actually adjust for it in terms of the workforce participation rate. So there was a part that on the supply side, the talk of participation, you can actually adjust for that using that lever. The issue of sensitivity analysis. So sensitivity analysis, remember that the model has so many variables. So I'll touch on the 3 of them. First, around the need for health workers, the one that depends on 4 factors: the disease burden, the essential package of services, the population structure along the life course, and then also the workforce productivity. Now, when you want to do sensitivity analysis, you have to do a structure such that you account for uncertainty along all the 4 elements. So when it comes to disease burden, that's easy because the disease burden data, the prevalence data for the diseases and risk factors actually comes with confidence intervals from the current estimates. So we are able to account, looking at those boundaries of confidence interval to account for it. And that is factored into the best case and worst case scenarios. When it comes to the population, it's also possible because majority of population estimate comes with medium variant, which is usually the one that often quoted, but there are also other variants of population growth. So you can actually account for that also. Then when it comes to the worker productivity, because we are looking at the time to deliver interventions along a continuum from novice to expert, we are able to also account for some kind of uncertainty of how much time is required to deliver intervention. Now, put all of this together, the type of sensitivity analysis that is feasible in the current tool is to do a best case and worst case scenario. So you can't do other type of sensitivity analysis, just the best case and worst case for now. Now, having said that, I wanted to touch on something around how do you factor in other emerging diseases or risk going forward. So the 2 models basically are speaking to each other. It's just from where they start, that is the different thing. So with disease burden, what the Afro model does is that it looks at the evolution of disease burden over the last 20 years and assume that the evolution into the future would follow similar pattern unless when the intervention changes the course. Then we try to model that evolution into the future and apply it for the workforce. So if a certain disease is, the prevalence is coming down, another one is going up, it to be able to adjust for that. Now, having said that, if there's the need to factor in certain, let's say you are doing the scenario planning for emergencies, because we also add data on the prevalence of diseases when there's emergency, you are able to make a scenario to cater for emergency. Should there be an outbreak, what do you require? So that is also possible to do. Or should there be a completely new disease, you can put a disease X or whatever you call it, and then you can do a scenario where you activate when you are having an outbreak like COVID came that was completely new. So these are some of the capabilities that are inbuilt in it, of course, and the limitations to know when one is trying to use it.
Thank you so much, James. But James, I'll come back to you. There's some unanswered questions for you on the chat, but I want to go to the TANZ group again. The issue of knowledge translation. I'm really passionate on this because I believe research is an investment and there must be return on investment. It takes more than a dialogue. It takes more than capacity building to get this into policy. So if you could point to some of those strategic points we need to touch to make sure that we generate evidence and it impacts policy development. I will also ask Jane to talk briefly of what do you think made it possible? Not what you did, but what made it possible. Tanzi, please talk from a regional perspective because you're working with many countries. And Jane, you talk very briefly about those core steps that really made it possible. I want to start with the Tanzi group. Anybody from the group, over to you.
Maybe I can start answering this. We also have Tim Hallett here in the office who could jump in. But I would say that the key design factor in the model from the start has been to work very closely with policymakers so that the academic exercise of developing of the model can really be informed by the needs and the requirements of the policymakers. So what are the questions that the policymakers are interested in addressing? How can the model cater to those needs in detail? So the development of the model has always been very closely informed by that ongoing dialogue with policymakers through think tanks and meetings and direct participations, so that we can ensure that the answers that are addressed by the questions that are addressed by the model are directly relevant to policymakers. And this is key to ensure that then this analysis can translate into policy and have real impact for the population that it serves. Yeah, okay. Bingling, I don't know if you want
time, I want to go to Jen for your reflections quickly, because we are running late and we have to answer the questions. So Jen, over to you.
Thank you very much, Juliet and colleagues. I think what made it possible was the global and regional guidance in terms of health workforce matters and the direction from the World Health Assembly. In addition to that, the buy-in from the top management, cabinet ministers, secretaries, and the Health Service Commission has been vital, plus the dedication of the team that was led by the WHO technical team in terms of being available, understanding the assignment and running with it, with support from the relevant principals. Thank you.
Thank you. So, participants, thank you. We've run short of time. Now, James, I want to allow you 1 minute, strictly, maybe even half a minute, to talk to, is it possible to allow supply, demand, and need iteration? And how is this interaction might affect how it plays out in the real world scenario? The question is on the chat, but half a minute, please, because then we need to move into wrap up.
Yeah, thank you. Yeah, it's possible to allow supply, demand, and need to interact, but based on a certain set of assumptions. In the real world situation, especially depending on the country income level, in low income countries, they don't look at need first. They first look at how much they have, and then they start from there. So you can see in some countries, they will control training basically based on how much money they have. But if you wanted to interact, then you have to work backwards from how much they have and to how many you should train. But in terms of getting need to influence, you can do the need analysis, use that to compare with how much they have, and then you adjust supply accordingly. So depending on your assumptions where you want to start from between the three concepts, you can allow them to interact.
Excellent. I think the other question will be answered online, although Alex, if you want to say something about that same question from the Tanzi model, briefly.
Thanks very much, Juliet. I think I was just going to add that if we haven't had a chance to get to your question live on the call today, not to fear, when we circulate the recording of the webinar afterwards, we will try to include text answers to any questions that we've not been able to address directly. Thanks very much, Juliet. Back to you.
Are you there, Juliet? You're muted.
Oh, sorry, my apologies. Sorry, I was speaking, I didn't know that I was muted. So I'm saying that I believe the recording will be shared, and the questions that we haven't been able to answer, the responses will be given in the same email. Now we are going to move to the wrap up, and in the wrap up, I will request James to give a brief wrap up from the WHO Afro perspective. Then we'll hand it over to Edward who will wrap up from the Tanzi side and also officially close the webinar. So James, over to you, please.
Thank you, Juliet. From WHO Afro perspective, we believe that robust evidence is an important part of planning the workforce and therefore shaping the health system capacity to deliver the services the population requires. And for that reason, modeling is an important tool to be used to inform the planning and the investment required in the health system. The two models presented here should not be considered as competing models. They are complementary, and as you can see, they measure the same thing. They can derive at the same direction of policy intervention and investment. And therefore, WHO and the Tanzi program are keen to work together towards complementarity in terms of how the models operate, but also building capacity for analysts, for planners, for economists across the region. So please feel free to reach out to us, either through WHO or through the Tanzi program, but we will work together to support you in how you apply these models in your context. Thank you. Juliet, and over to you.
Yeah, thank you very much, James. I think I can't say it better than you have put it there. I think there's room for us to collaborate, you know, Tanzi and the WHO. There's still room for us to collaborate, and we're looking forward to working with you. I think with that, we already passed, you know, the half hour mark. So this brings us to the end of our webinar. And what remains is for me to thank everyone, our presenters for the excellent and insightful presentations, our participants for your active participation, but also for the excellent moderation from Juliet. Now, I think in closing, just a few things, announcements. First, I think as Alex has said, we are going to share a recording of the webinar, which will include any questions that might not have been answered, but they are there in text. We are going to share that together with the answers. That's first thing. And then second, to just announce that we are going to have another webinar, which we are again jointly organizing with the WHO, still on the issue of health workforce. And this is going to be on community health workforce. It's going to be held in a month's time, within the month of May, at a date that is yet to be confirmed. But we are going to announce this as soon as the date has been determined. And then lastly, I just want to mention here that the Tanzi program has we have Tanzi studentships, where the University of York offers studentships for a master's program in health economics, and that's what we have there on your screen. We have now opened for applications for those people who are eligible. So this is just to inform you that we have these. Those who are eligible can apply. We have the QR code there. If you're interested, you can scan that and then maybe share with people who are eligible to apply for this. So that's what we have by way of announcement. But otherwise, I would like to once again thank everyone for attending the webinar. And we look forward to seeing you again in about a month's time for the next webinar, which we are going to jointly organize again with the WHO Afro. Thank you very much, everyone, for your participation. The webinar will now be brought to a close. Thank you.